I've been presenting doing these cases about 15 months or so in an outpatient lab. What I wanted to bring here was a contemporaneous case that I've done recently, actually as recently as this Friday, about what can be done, what is done, what are the outcomes. But the key element to doing these procedures is get them in and get them out. And there is this decisions of go, no go, where you come to a point where you say, I've spent too much time and I don't think I should spend any more time. Call it off. You always have the liberty of taking these patients to the hospital and either doing the procedure or finishing that procedure over there. So that's what we do. 71-year-old clinical, Hispanic woman presents hypertension for 25 years, diabetes for 15, hypercholesteremia for about 20. She has had CAD. She's had PCI ×3. Her LV function was preserved as I knew her before. She's a non-smoker and was compliant with the medical treatment and all the therapeutic lifestyle changes that she's done. Comes in severe cramps in the legs that led to a precipitous drop actually in effort tolerance over 6 months. And for the past month had noticed that her leg cramps were lasting much longer. And the past few weeks, she had numbness on the right foot, and it was the right foot that was more symptomatic, hobbling into the clinic when I saw her. In clinical examination, normotensive with a high blood pressure of 119/56 with a 59 heart rate. Creatinine was 1.2. Both of the lower extremities were cool to touch, and there were areas of hypersensitivity on the dorsum of her right foot. There were no palpable pulses, and the ABIs that were done in the office at that time were the 0.5 and 0.6 right and left. Brought her in, had the diagnostic angiogram done that showed this on the extremity that we accessed first, and went on to contralateral side to look at the SFA that had significant disease. But looking below the knee, she basically had total occlusion of all 3 vessels, and doing selective angiography of these, the anterior tibial was completely occluded. And further down, the posterior tibial also had a chronic total occlusion. And selective angiography from the catheter, which was a Win 0.014 system, saw that there was a long total occlusion of this vessel. So at this point in time, the decision was made to at least give her 1 vessel revascularization here. And we got lucky insofar as the wiring, catheterization, ballooning, and atherectomizing her. And the key to this was that, as you're faced with a vessel like this, a lot of times you can get through, a lot of times you can't get through. But the idea is that there has to be a point of calling it off and saying, it's like, I think I've used all the tools in my toolbox, and I think I'd take this patient for a more aggressive intervention at the hospital and not use an extensive amount of time doing that. So we got the small balloons through, and as you can see, there are multiple areas of severe stenosis that we addressed. Got a tapered long balloon in her, and the end result ends up something like this. We did atherectomize her, and the final result on this patient going into the leg and then going to the foot. So with an inline blood flow to her leg and her foot, all done with a floor time of 1523.6 seconds and 183 milligray. So total procedure time of 1 hour and 10 minutes and inline flow to the foot with a reasonable radiation dose and 35 cc's of contrast. Actually saw this patient this morning before I came here. Her right foot is significantly better. She still has occasional pain, the hyperesthesia sensations have gotten better, and she's not getting those consistent cramps that they were. So, there is a outlet that is available to us where we can help these patients that walk in through the door. When it comes to case selection, sometimes you are very generous in what you get, and sometimes you get what you get, and you try to do the best that you can in trying to help these patients. Thank you very much for your attention.